Awesome. Well, thank you guys so much for joining us today. Our webinar topic is standing up for health and wellness following spinal cord injury. And we're going to be focusing on supported standing devices and robotic devices. So I'm going to introduce myself and then I'm going to let our co-presenter Jill introduce herself. My name is Kristen Cesat and I am a physical therapist. And for the last 13 years, I have practiced clinically at a more on the acute side of rehab in the inpatient rehab setting, primarily with adults with neurologic injury. Spinal cord injury has always been my area of practice. That is my passion. And for the last 7 to 8 years of my clinical practice, I was the clinical specialist for our spinal cord injury program in the organization that I'm a part of. I still do treat clinically a very small amount, but my primary role now is as the clinical education specialist for Ultimate Medical. I also am an adjunct faculty for a physical therapy program down where I live in Florida, and I help with their research series of their portion of their curriculum. All right, I'm going to turn it over to Jill.
Thanks, Kristen. So my name is Jill Butler. I'm also a physical therapist. I'm based in the Boston area, a little south of the city. I spent the beginning of my career also focusing on adult neuro treatment, a little bit of inpatient, a little bit of outpatient, did that for about 12 years. And then the past 6 years or so, I've transitioned over to industry, to robotics specifically. And so I started as a clinical training manager, and now I am the product manager for the Rewalk device. At LifeWord now. So we somewhat recently, it's almost a year now, rebranded to LifeWord, but you may have known us in our previous life as Rewalk Robotics. I'm happy to be here. Thanks, Kristen.
Awesome. All right. So we're going to go ahead and get started. So our disclosures that we both have to include is that I am a full-time employee of Ultimate Medical, as well as Jill is a full-time employee of LifeWord. All right, so as we get into our objectives today, we're really going to discuss two common technologies that are currently available, both clinically and for home use for individuals to participate in upright standing and walking activities. So we know there's more and more technologies that are becoming available over the last 2 decades to help individuals with severe spinal cord injury and other neurologic diagnoses to return back to participation in activities for standing and walking. So as we go through this, we're going to discuss how to really dig into what are your individual clients' goals and expectations for the technology that you are introducing. How are these goals going to change and evolve over the individual's lifespan after their spinal cord injury? We're going to look at some of the clinical reasoning and evidence behind both supported standing devices as well as robotic devices. And then we're going to look at how do we access these devices for individuals for home use after their injury. So let's go ahead and get started. All right, so first we're going to look a little bit just at some basics of spinal cord injury that we need to consider anytime that we're getting into the topic of any type of technology to help an individual to stand or walk. So the international standards for neurologic classification for spinal cord injury, or the INSCI exam, or the ASIA exam, as many people know this, is still the gold standard clinically to help us to be able to identify the type of spinal cord injury that a person is experiencing, as well as the level of their injury. So it's really important as healthcare professionals. We know a spinal cord injury is not a spinal cord injury is not a spinal cord injury, that we are communicating amongst ourselves and amongst our team, as well as with the individual, of the level of their injury as well as the type, because that's really going to help with the big picture of starting our clinical decision making. So this tool, as you can see here, breaks it up into several categories or ASIA impairment scales. And what we're really focusing on for today's conversation are those more individuals with more severe injuries. So we're looking at that ASIA A, which is our motor and sensory complete injuries, as well as our ASIA Bs and Cs, which are either sensory incomplete or very weak motor incomplete. Those are typically the individuals that are needing the most assistance with supported standing or returning to ambulation participation following the paralysis. Our ASIA D category, although there are some individuals who still require technology to assist, is really our most highly likely individuals to return to walking function under their own power. So just some things to kind of think about for the context of today's discussion. All right, when we think of the physiological effects after spinal cord injury, we know that there is a whole host of things. There's really not a system of the body that a spinal cord injury is not going to affect. So we have to think beyond just the traditional paralysis and sensory changes that we know are going to happen. How does that spinal cord injury impact their bowel, bladder, and sexuality function? Their respiratory function, we know the higher the level of injury, the cervical spine being the most affected from a respiratory capacity. But really, anybody with an injury as low as T12 is still going to have some deficits for their respiratory function just because of the inspiratory and expiratory muscles being affected. The autonomic dysfunction that will occur in our individuals with T6 injuries and higher. And autonomic dysfunction is going to include things like orthostatic hypotension, autonomic dysreflexia, thermoregulation challenges, which is the inability to regulate our temperature appropriately, as well as some of the heart rate responses that may occur when we are trying to do interventions like supported standing and walking. And then lastly, looking at spasticity. Spasticity is something that is going to change and evolve a lot over those first few months after injury. And is something that, as we get into the evidence behind the interventions we're going to be discussing, really is something that is can very significantly affect an individual's life and function after injury. Once we look past those physiologic impacts, if you've been in spinal cord injury rehabilitation for a while, these main complications have been in the literature for decades. And while we are making improvements in these areas, in these secondary complications, we still have not solved these problems. They are still emphasized and prioritized by rehabilitation professionals across the industry as how are our interventions not just affecting function, but how are we preventing and reducing some of these secondary complications that we know can significantly impact an individual's life, their function, their financial impacts that come with being rehospitalized or experiencing any of these issues that you see above. So anytime you look to the literature, these are the common areas that we're going to see discussed the most and what we are prioritizing often as PTs, OTs, ATPs. All right, so when we look to the literature again, we also know that individuals with spinal cord injury are living a sedentary seated lifestyle after they experience their injury. It's all over the literature right now in looking to find ways to increase participation and physical activity and wellness following spinal cord injury. So there are two real ways that we as clinicians are looking to do that, whether that's seated and active for some individuals or standing and active for some individuals. So really our emphasis is we want to get away from that sedentary lifestyle and move towards that activity and promotion of health and wellness. But for today's discussion, we're obviously looking at how can an individual be standing and active following their spinal cord injury, especially for those with those more severe presentations. All right, so we're going to get a little bit into supported standing devices and clinical decision making first. So anytime we get into this discussion, we're going to talk about evidence-based practice. We're going to talk about it related to supported standing devices, but also for robotics. But it's really important to remember that evidence-based practice is this triangle. Each of these three pillars is going to be essential to being able to practice an evidence-based manner. So when we think of this, we often think of the body of literature that's available to us, right? That's what a lot of clinicians' mind goes to first. And what is the best available evidence as we're looking at that time? It's important to remember that the evidence is going to change and evolve. So we have to stay up to date with the current things that are coming out. But equally important is also our clinical expertise and our experiences as clinicians to help us with the different reasoning and decision making that we are doing in our practice. And then lastly, if not the most important, is going to be the patient's preferences. So each one of these aspects is very, very vital to evidence-based practice. When we look at patients' preferences throughout my career, obviously we know that that is a major driver in our decision making. But I have married into a family that has two individuals with spinal cord injury. And over the past 15 years, one of them is a full-time wheelchair user and the other is semi-ambulatory, but uses a wheelchair for community distances. So it's been really interesting outside of my clinical practice and into my personal life to see how much a person's preferences are really the most important part of why we do what we do as rehabilitation professionals. As I'm watching and helping through the aging process for my family members, I realize that what I think is important is not always what they think is important. And that's going to drive a lot of the decisions that are being made. They often tell me, as we discuss things like, Kristen, I get where you're going, but I'm just not ready for that yet. So those are really important things as clinicians that we're taking into consideration in this process. All right, so when we start talking about clinical decision making to decide, okay, we would like to start a supported standing program of some kind, where do we start? It's really important that there's a whole host, and this is what makes this process so fun and exciting as a rehabilitation professional, is all of the different pieces of information that we have to synthesize to help match the right technology for that individual at the right time in when they're seeking intervention. So the important aspects are going to be the type of injury that they have, what level is their injury. If we're talking early after spinal cord injury, what is their prognosis? What is the prediction that they may return to walking or standing under their own power? Or are they going to need complex rehab technology or robotics to help them with those goals? Obviously, we have to know what the client's goals are for the device. And this is one you're going to hear Jill and I talk a lot about. You got to dig deep. Everybody's going to tell you, especially in the first, year to several years, I want to walk, I want to stand, I want to, but what does that mean to that individual? Because we have to make sure that we are matching their expectations for that device with how it's going to actually function in their life to be able to have a successful outcome for that person. So we've got to know, how are they intending to use a device? What inner environments are they planning to interact with? And all of those different details. They're major driver in some of the decision making for the types of devices that we are seeking. If they need caregiver assistance, do they have that assistance available to them? Obviously, funding is a major discussion point, but you can see it is not the first on the list that we are going to talk about today. As an assistive technology professional in ATP, we learned that funding is not it's not the driver in why we introduce technology to an individual. If an individual has goals, we want to match that technology and then figure out this for them. We don't show an individual technology based on, you have this insurance, so you get to know about this, and you have this insurance, you don't get to know about that. That's unethical and not the way that we want to promote equality and equity across technology for individuals. And then lastly, looking at all of the social determinants of health that are going to impact the use of the device. So each one of those is going to play a role in perhaps the type or reason why we're choosing. Then your life roles in on this side, and knowing that these are going to change and evolve over the lifetime as that person changes and ages with their injuries. So it's important that we are constantly staying up to date with the client's needs and goals and wants. Now, when we look at supported standing devices specifically, there is a group out of Europe that has come out with, there's not clinical practice guidelines that exist that tell us, very, very robust thought processes behind how and when we should do different technologies for supported standing. But there is a group that has come out with some guide literature that helps us to give us some guidance on the available evidence that is currently in practice. This came out in 2019, but they discussed that the use of supported standing intervention should start as early as possible, and that the technology needs and goals are going to change and evolve over the lifetime of an individual. So again, we have to look at all of those different aspects for prescription for home that we kind of just discussed, but knowing that there isn't one piece of technology that is going to meet every single need that that person's going to have for the rest of their life. It's often matching different pieces of technology throughout that individual's lifetime. So those are very important things that we need to think about. All right, so when we think about ruling in or ruling out using a supported standing device in clinical practice, especially when we think of early clinical practice, early after their spinal cord injury, it's important that we're considering, when we're ruling in a device, what are their goals? Do they have goals for standing? Step number one, right? We're really thinking about using these devices in individuals that are non-ambulatory or have very poor ambulation function. So those that absolutely have to rely on their arms at all times for standing, have poor endurance to stand, high fall risks in their outcome measures, and things like that. We also want to look at medical stability. So we need to show that we are stable throughout this process. It may not be initially when we first get up. We may experience some of the orthostatic hypotension related things, but with continued trials, we should see improvements in making sure that that individual is medically stable as we utilize these interventions. We need to make sure that the individual's height, weight, upper leg length, and lower leg length are going to be appropriate for the device that we have selected that we want to trial. We've got to make sure that we respect and understand the manufacturer's recommendations. If we have a weight limit, we need to stay within that weight limit. So it's important that we understand that for the device that we're choosing. And then again, know your state's funding qualifications as you're starting to kind of rule in what devices you're considering. There are some times, though, that early intervention isn't necessarily appropriate for somebody, and we may have to defer standing to a later time. Obviously, any time for indications to standing, whether that be an active fracture or weight bearing restrictions. I worked in a trauma center for most of my career. I saw many individuals where their spinal cord injury was like the third problem on their list because they had so many other medical complications. So we may have to defer standing until it's medically appropriate to do so. We're not necessarily going to use these devices for individuals who have a very, very high likelihood to return back to walking again. So we may use it early in clinic, but not necessarily a home prescription for someone who's going to regain functional walking. If the client doesn't have goals for standing, and every once in a while you do meet those individuals who it's just not a priority for them, or if that individual needs help to use this device at home and has no one to do that. So that's sometimes that we may have to defer that kind of consideration for home until we have a change in social situation that they have someone that can assist them if needed to use that device. All right, so we know that there's two ways that we're going to use supported standing devices, and one is clinically. How do we use this in clinic? And one is going to be for the individual to use at home. So we know in clinic, we're using a lot of different interventions. We're doing things functionally. We're working on balance in ways in standing that we couldn't do in sitting or other positions. Strengthening of the trunk, arms, legs, depending on the type of injury, weight bearing. We're doing a lot of different exercises, stretching, and spasticity management. So there's a lot of rationale for clinical utilization of supported standing devices. But again, we have to think about when we're starting that program either early or for the first time, if they haven't stood in a while, think of the considerations like orthostatic hypotension and making sure that we're monitoring their blood pressure and accommodating for that as needed. We're looking at autonomic dysreflexia in those individuals with higher levels of injury that we may have to go very slow through the standing process. And if we see changes in blood pressure, we may have to accommodate for that and then try again. So vital monitoring is going to be essential as we're introducing this. And obviously, if the client has a very chronic injury and we have concerns, then we need to address that with the physician. All right, so as we look at the different types of supported standing devices that are available for adults with spinal cord injury, there are many different things, and we're going to look at what does the evidence say. So under the supported standing device category for complex rehab technology, we have different technologies available. So we have tilt tables. We all have seen those in clinic. We use them in early intervention, sometimes the first time we get somebody up, but they're not really a home prescription device. I don't think clinically I have ever seen one for home, but I'll never say never. When we start thinking about both clinical application and home application, we start thinking of standing frames, which can be both static or mobile. We think about manual wheelchairs that have a standing feature integrated into the chair, or power wheelchairs that have a standing feature integrated into the chair. So those are kind of the different technologies when you're going to hear us talking about supported standing devices that are going to fall under that. Jill will talk about the robotics here shortly. So these are the different things in the literature that are in different studies that have been done related to supported standing. So again, that early intervention piece from the group from Europe is talking about how clients should be individually assessed for standing as soon as the person is physiologically stable and it is practical to do so. And that's going to look different for each one of us in the clinical environment that we are a part of. But noting that the earlier the intervention is started, the more we can stay ahead of some of the complications that we'll discuss, like contractures or severe osteoporosis, those types of things, the more successful that our standing programs can be. And then looking at the dosing, and the dosing in the literature for supported standing devices right now is anywhere from 3 to 4 times a week or more for about 30 to 60 minutes per standing attempt. And then we're going to kind of go through the evidence on these different topics. All right. Anytime we talk about complex rehab technology or a supported standing device, we have to tie it to function. That is the only way that we can get a device like this funded is we have to have functional goals and utility for that device. So obviously, anytime we give someone the ability to reintegrate back into the vertical environment, think of all of the things that you can do in a standing position that you're unable to access from a seated position. So things such as, domestic activities in that vertical environment is going to help improve participation for that individual. There are survey studies that talk about individuals who were participating in a standing program reporting that they had improved ability to participate and perform their ADLs. And then knowing that a standing device is beyond we're not just standing just to stand. We can also do things like exercise within that standing platform. And it's really important that we think about the different recommendations that are currently out there for individuals with spinal cord injury as far as exercise. So we know that right now the guidelines tell us that we want to be aiming for, 20 to 30 minutes of aerobic exercise 2 to 3 times a week or more, as well as 2 times a week for resistance training. So sometimes a supported standing device can be an excellent tool in combination with the functional ways that an individual uses a standing device to accomplish some of those guidelines to live a more active lifestyle. When we talk about spasticity in the literature, Dr. Field Fote in 2021 did a study titled Characterizing the Experience of Spasticity After Spinal Cord Injury. And this was a national survey project of the spinal cord injury model systems centers. And it really was the largest survey study of its kind. They had over 1,000 participants, and they were looking at the details of individuals' experience with spasticity after their spinal cord injury. And there was really multiple very important things that I think came out of this study. But one of them was that respondents to the survey indicated that spasticity was improved more by stretching and exercise than by using antispasmodics for those that responded. Now, important to know, we are not telling individuals how to take medications. Medications are still an important part of spasticity management. But I found it really interesting that individuals with SCI are using stretching and exercise as part of their spasticity management program. So we as clinicians need to find the ways to help individuals and dose their stretching and exercise programs appropriately for each person to have the best impact and outcomes on spasticity that we can. Obviously, a supported standing device is a great way to do all of those things. We can weight bear through the lower extremities, we can stretch the lower extremities, as well as participate in some exercise. So you can do multiple things at once to have that impact on spasticity that an individual may be looking for. When we think of range of motion and stretching, it's not really rocket science. If an individual is a full-time wheelchair user or in a sitting position more often throughout the day than anything else, we're looking always as clinicians for ways to improve range of motion and prevent limited available range of motion at the hips, the knees, and the ankles specifically. So we're trying to prevent contractures. So this study was done actually in a group of individuals with MS that were wheelchair users, but they found statistically significant improvements in ankle and hip range of motion versus the control exercise group. So individuals that were standing were seeing more improvements in their hip and ankle range of motion. Survey studies also find similar results that individuals that are participating in a standing program report the ability to straighten out their legs better than those who are not participating in a standing program. So in addition to other interventions, supine, prone, a standing program is a great way to mix in another avenue to be able to stretch the lower extremities for prolonged periods. When we look at bowel health, a lot of the evidence in this area is very anecdotal. So there is not robust, high randomized controlled trials in this topic. The clinical practice guidelines that are available for spinal cord injury, they have them on a variety of topics from the PVA and the Spinal Cord Injury Consortium. 11:25 a.m. The PVA has a bowel health guideline that says a standing program may be beneficial for bowel management for individuals who cannot stand or walk regularly. So those that are having a lot of challenges with constipation or the time that it takes to complete their bowel program, for some individuals, a standing program can be beneficial to help with that process. It's mostly survey study that is in it that discusses individuals reporting that a standing program improved their bowel function. Cook et al. In 2015 they did a study on a small study on 17 individuals where they used objective outcome measures for individuals in a standing program. And while they didn't find statistically significant changes in the outcome measures that they looked at, they do talk about in their discussion how 8 out of 17 of the participants reported that they felt that standing was helping with their bowel function. So it's a difficult area to quantify some of these changes in individuals. So we really have to look at this on each individual person and is this a goal for them or not? When we look at pressure redistribution, again, it's when you think of the main areas after spinal cord injury that we're most concerned with for individuals is often the pelvis, right? The ischial tuberosities, the sacrum. So being able to change position off of the tushy, the bottom, is a priority for a lot of individuals to help prevent wounds in those areas. So when we think about standing, though, we have as clinicians to have to make sure that we are also reminding clients and teaching them how to do skin assessments of the lower extremities. So if I'm now standing, putting weight through my legs and my feet, I need to make sure I have proper shoe wear, anywhere that contacts the feet, the knees. I'm doing good skin assessments before and after to make sure that I am not having any issues in areas that are not typically taking weight, that now we're starting a weight-bearing program. Sprigel et al. In 2010 did do a very small study. This is a case series, but their group looked at tilt, recline, and standing systems and said that all three should be considered for a means of weight shifting for individuals that are wheelchair users. And then when we get into psychological, so we know that a lot of individuals have goals after their injury to want to stand and walk again. So across the literature, there has been a huge emphasis in our entire healthcare system on mental well-being and psychological health for all individuals, but specifically for those after spinal cord injury. So there are several surveys that showed improved well-being and quality of life in those with chronic spinal cord injury that were participating in standing programs. All right. And then lastly, as we get into the bone mineral density discussion, and this is probably the one that we get the most questions about across our industry. So when it comes to bone mineral density, it's important to remember that individuals with spinal cord injury are going to experience bone mineral loss early after injury. This is not just a chronic consideration. That really in those first weeks and months, we are seeing, Edwards et al. And Frey-Rendova et al. Found that bone loss in the lower extremity trabecular bones was as high as 40% in that first 6 months. So we're not just thinking chronic when it comes to this. Now, it is important to remember that the evidence, and this is only for adults with spinal cord injury. We are not talking about any other diagnosis or age group, but for adults with spinal cord injury, there is very inconsistent and mixed evidence as to passive supported standing interventions alone and the impact that they have on bone mineral density. These studies that do show positive impacts are those that were started very early after spinal cord injury. They were continued long term. So one of the studies was done for 2 full years, and an individual stood in high doses. So those are important things to think about if bone mineral density is the goal or the conversation for that client. But otherwise, short duration, intermittent, not having high frequency, none of those studies show any statistical significance in bone mineral density impact. So again, when we look to the clinical practice guidelines, which are a go-to for individuals, for healthcare providers that are treating individuals with spinal cord injury, in 2022, the PVA and Spinal Cord Injury Consortium updated their clinical practice guidelines for bone health and osteoporosis management. So they did come out with several statements related to supported standing or passive standing. The first being that we may consider passive standing for 1 hour, 5 times per week for at least 2 years to reduce bone mineral density decline at the hip and knee. So I think that's important for us as clinicians to remember that we can't expect to do this intervention 4 times in clinic and never stand again and have any kind of impact really on any of these things that we're discussing. Frequency and dosing is going to be important. So we're going to talk about access to a home program because that's going to be the key for many individuals for their goals. They do discuss that there is a minimum duration of 1 year of muscle activated and lower extremity load bearing before we even expect to see any impact in bone mineral density. So that combination of muscle activation and weight bearing is important. And for some individuals that have incomplete injuries, we can do that. But for individuals with motor complete injuries, we may have to look at combining technologies. So utilizing things like electrical stimulation to help with that muscle contraction during standing. Knowing, again, like we just talked about, that muscle activation load bearing needs to be continued indefinitely, and that right now there is not currently an established threshold for bone mineral density value in which there is an absolute contraindication to supported standing. We get that question a lot. How long is too long that someone hasn't stood that we should say this isn't safe to do so? And there isn't a direct answer to that. So it's important, and the group talks about that we have to consider obviously the DEXA scan, the bone mineral density results, but we also need to think of other factors such as their history of fragility fractures. Do they have contractures present? What medications are they taking? All of these things to put together a clinical picture to decide whether standing intervention is appropriate to do so at that time. Obviously, when in doubt, consult your physician, but just knowing that there aren't any established guidelines currently that are available to us. So those are kind of the important things to think about. And then knowing that that early intervention is going to be important because right now there isn't any evidence that passive standing is effective for treating bone loss. So if somebody already has osteoporosis, we're not going to undo that osteoporosis. But that they did discuss that there was no adverse effects reported in the studies that they looked at with passive standing. So that did suggest that those risks were low. So just some considerations because that is always probably one of the top thoughts in clinicians' minds. Oops. All right. So when we decide that we know the evidence, we're ready, we've gone through our decision making, we want to start a supported standing device. Again, it's important that we look at their height, weight, their upper leg, and their lower leg measurement. That's going to be important to helping us to fit that device right. Because if it is not fitted appropriately, then it's not going to be comfortable. Their joints are not going to be aligned appropriately, and we could be risking abandonment because the person's not going to want to use it if it's not feeling comfortable to their body. But we also don't want to risk injury by putting someone in a device that does not fit appropriately. So those would be the key considerations for any standing device that you're utilizing. So just to kind of sum that up, our timing of when we're starting the intervention, we have to think of all the clinical considerations as to when is the right time. But obviously, the earlier we can do it, the more advantageous. And then looking at those frequency and dosing recommendations that we discussed earlier. All right, so we're gonna let Jill take over and talk about exoskeletons.
Awesome. Thanks, Kristen. A ton of good information there. But yeah, as Kristen said, we're going to move to the exoskeleton portion of the talk now. And I've structured it so that it mirrors that beginning portion so that the intent there is that it allow everybody to more clearly see the similarities and overlap of the two technologies, as well as the differentiators between the two. You can go to the next slide. So when thinking about exoskeletons, I find it helpful to break it into these two categories. There are the rehab-based ones, that both overground and over treadmill, that I think the majority of clinicians are more familiar with. And so today we're going to be focusing on what we refer to as personal exoskeletons, which are the ones designed and cleared for home and community use. So in that category of those that are designed and cleared for home and community use, there's currently 2 on the market. On the left, you see the Rewalk, which is now manufactured and commercialized by LifeWord, which, as I mentioned at the beginning, was previously Rewalk Robotics. And then on the right side there, you see the Indigo Personal, which is now commercialized by Exo Bionics. They're both similar in that they essentially have rigid components from sort of the chest down to the ankles, and require some user interface, right? So they're not just doing all of the work on their own. The user has to select the mode, et cetera, and lean with their trunk and sort of interact with the device. And so there's a lot of similarities and a couple differences that we'll get into next. So clinical decision-making, when you're thinking through which of those two is the right choice for my patient for at-home and community use. Level of injury is going to be one of the first things that should come to mind. There are slight differences in the level of injury. The Indigo can actually go a little bit higher, up to the level of T3, and the Rewalk is designed and cleared for T7 and below for home and community use. So not a huge difference, but just something to consider. Another piece of this is the desired use. So as Kristen mentioned, it's super important that you really just dig in and have these discussions with their patients beyond just, oh my God, I want to stand, I want to walk. What do you mean? Like, where are we going to be doing that? How often? What kind of environment? And so if it's an environment with stairs and curbs, that would be a consideration for the Rewalk, because only the Rewalk has that labeling indication to do the stairs and curbs functionality. Additionally, sort of this discussion and thought process around durability versus transportability. So the Rewalk is more so designed a little bit more robustly for sort of aggressive, prolonged use. But because of that, it tends to be a little bit less transportable. Whereas the Indigo, you can sort of easily, it says a modular design, you can pack it up into a duffel bag. So if you have a patient who realistically is going to be traveling around and bringing their device from place to place, then that might be the choice for them. Upper body function and balance. So both devices require upper body assistive device. The Rewalk, we really encourage just crutch use. We think it encourages a little bit more of a natural gait pattern. And so we don't generally have people use a walker, but the Indigo does often have people utilize a walker. And also because they have the higher level of injury. So either way, your patient's going to need some of that upper body and arm function, but a little bit of nuance when you're thinking about one product versus the other. Another piece of nuance would be their ankle status, sort of in general. So with the Rewalk, there's the added functionality of adjustability at the ankles. So it sort of functions like just your average adjustable AFO down at the ankle, where there's a dorsiflexion stop anteriorly and a plantar flexion assist spring posteriorly. That can sort of help accommodate for range of motion restrictions, as well as make the gait pattern, again, a little bit more fluid. And then patient preference is obviously bolded here. That probably should have been first, but I'm using it as my sort of like bow at the end there, that you can't overlook the importance of patient preference. And in fact, we encourage clinicians to be able to speak to both products, present these facts to them, work through this sort of thought process with them. And if someone is on the fence, then let them try both pieces of technology. Both companies have programs where they can come out and help you trial it. And we find not every patient, some patients it's a slam dunk which one they prefer. Some patients really aren't sure, and we have them try both. Okay, on to the next. So this is sort of a general discussion, ruling in, ruling out. Obviously, there's slight differences in the labeling, whether it's the Rewalk or the Indigo, but this is sort of a general guide. And it is a little overwhelming when you first look at it, right? And so when we're sort of introducing clinicians to the idea of identifying potential candidates, talking to your patient about it, sending in a referral to the company, the main thing we want you to know is that you're not alone in this, okay? A lot of therapists, you know, we have big hearts, we have big shoulders where we carry heavy loads for a lot of things, and we're used to sort of being the workhorse of the team, I think. And feeling like we have to be the ones to dig into every single little thing. But there's a lot here, and there's a lot of things that are, for one thing, modifiable. And there's a lot of things on here that truly you can't assess in your clinical practice. And so we encourage you to sort of mostly look at the ruling inside and look at the handful of things that are truly non-modifiable and pretty easy to identify, actually, when you're just in the clinic with somebody. So it's that, again, that's level of injury, hand and shoulder function, age, there's some height and weight limitations depending on the device. Again, the goals, client has the goals for walking. Let's keep circling back to that and getting those expectations in the right spot. Kristen did a great job of touching on the bone density piece, and it's the exact same for exoskeletons. And so the guideline is that it needs to be, quote, healthy bone density. And so that's to the discretion of the prescriber, the MD. And so a little bit DEXA, a little bit other risk factors, history, meds, etc. But don't get super hyper focused on that. You can't solve that yourself in the clinic. So the recommendation, like I said, is sort of get the process rolling, have the conversation with your patient that this is a multi-level screening process. And so if they're excited and they're wanting to begin the screening process, great. You know, they've hit the couple that are definitely need to be hit in terms of what we already talked about. And they need to know that there's things that may come up in the screening process that either may delay their getting it if they something they need to modify, range of motion, etc., or may end up ruling them out eventually. And so again, it's just a conversation you want to get used to having, just open and honest with your patients versus sort of taking it to the extreme cautious end and sort of over screening and over ruling out folks that could potentially benefit if you had sort of given them the chance to walk through this process with the clinical and medical teams at the device companies. All right. And so another sort of visually overwhelming slide here. But essentially, it's just to show that there's an abundance of evidence showing not just safety and efficacy, but also significant health benefits with personal exoskeleton use. It goes all the way back to Dr. Eskenazi out of Moss Rehab in 2012, sort of showing that was for our clinical trial to get FDA approval. So the basics of safety and efficacy all the way through 2023. And actually, I'm going to review some studies even more recent than that. So there's definitely a plethora. The things we're going to hit on next in the next few slides are the things that have the most robust data to sort of back up the claims. Okay, so activity and participation, this one maybe seems a little bit obvious. But what, our favorite sort of tagline is that it's more than walking. So we'll get more into that, but it is also walking. So with this device, you'll see improved gait function beyond what patients can achieve with KAFOs. So improvements in their 6-minute, 10-meter tug. And then users, when they're out in the field and actually have these devices in their homes, they are reporting using them, mostly outdoors, but some indoors. And anywhere from 1 to 5 times per week is the most commonly reported usage pattern for folks in the home. So essentially, these devices can be a tool to facilitate what Kristen mentioned, hitting those goals of getting folks the recommended activity levels to keep them healthy and well after their injury. There's data, and we'll get into it a little bit in the cardiorespiratory slide, but just showing that utilizing these devices gets folks that moderate to intense level of cardiorespiratory exercise that we're having such a hard time getting prescribed for them and with what we currently use. Enhanced social interactions, meeting and talking people eye to eye. That can't say enough for that. It is, there's no data surrounding that, but that's something that comes up time and time again, is how important that is for folks. And then ambulatory access to environments with stairs and curbs. Obviously, the majority of our world these days is ADA compliant, and folks can access the vast majority of where they need to in their chair. However, that being said, there's definitely places in the world that require just one curb or a couple steps. Family private homes is a huge one for this. Small private businesses sometimes. And so that's another huge piece of this that we've found that users really value. Okay, pain is an amazing one. So in an intervention-based study over 24 sessions, users reported significant pain reduction. So that was Van Ness, just posted this year. Additionally, in 2019, Shackleton dug a little bit deeper and the systematic review, seeing that there was reductions in pain intensity both within a session and across intervention. So this is very common that we see after users only have a trial or 2 days in it, that they notice significant changes in their pain sort of right off the bat. As well as some users such as Jean, who's pictured here, who are able, with long-term usage, are able to come all the way off of their prescription pain medication. All right. All right, spasticity. And as you can see this, like I said, it does definitely mirror some of the stuff that Kristen talked about earlier. So spasticity, as Kristen mentioned, is tough to objectify and to study. However, there's a systematic review by Miller from 2016 that does report improvements in 38% of participants. In our rewalk surveys that we do for users who are, again, out in the world, just sort of moving and grooving, using their own devices, we see 50% report improvements in spasticity. And then this here is Carlos. He has his pump. He didn't refill his pump, so he's not currently using his baclofen, and he's in talks with his doctor. He wants it actually all the way removed. So there are definitely cases where there's a very significant life-changing difference in the management of their spasticity. So this is maybe, I mean, they're all important. I think I've said like 9 times, this is the most important and critical piece, but this is, again, the piece of it's more than walking. So as we know, our patients with spinal cord injury are not currently hitting the guidelines for moderate to intense aerobic activity. And so study in 2021 looked at cardiovascular fitness and found an improved likelihood because we're seeing increased oxygen consumption, elevating their heart rate, and increasing the RPE to at least moderate intensity exercise. All right. And as Kristen again mentioned with bowel health, it's mostly the studies are user report. But so we're seeing average time reductions for amount of time needed to complete their bowel programs, as well as some reduced need for external help, which are both, very important for quality of life. And then regularity as well. So 61%, that's Miller in 2016, reported improved regularity of their bowel movements. So psychological, when we look at the differences of using an exoskeleton after a training period, we see overall improvements in the SF36, as well as significant improvements in the subdomains for bodily pain, social functioning, mental health, and general health perception. This is such a huge thing that, when we interview healthcare professionals, doctors and therapists alike, this is one of the main things that we're struggling to help our patients with. And if this sort of isn't as well as it can be, that can affect so many other areas of their health and of their daily life, and whatnot. So it's really exciting to see more data coming out that justifies and really objectifies something that we inherently sort of know to be true. All right.
So we're going to look, Jill and I are going to kind of share this portion. We're going to look at access to these devices and what does that look like? Because that, of course, once we understand we're using this in clinic, our clients, how in the world do we get them for our clients? So let's kind of run through a couple of the important key pieces. So as far as access to supported standing devices and exoskeletons, first and foremost, we have to trial them in clinic. So we cannot just blindly give these devices to individuals without trialing the equipment, training the individuals how to use the supported standing device or the powered walking device. And then again, for individuals with that, when we are doing this in clinic, we're often using interventions in inpatient and outpatient that involve all of this technology. But it's when do we start to say, okay, this is the right device for this person for home. So once we have trialed it in clinic, then the next steps are to find those access pieces to help that individual to maintain this program for the lifetime, really, or as long as that is deemed appropriate for that person as a goal. So getting access to a personal device for the home setting, we have to look at what are their qualifications for the supported standing device, which are going to involve medical as well as functional justification through a letter of medical necessity. Now, for a supported standing device, we go through the same steps that we would a wheelchair that we'll look at, but it's going to be a little bit different for the robotic piece of it. So Jill will talk to that in just a second. But the personal exoskeletons require more of that medical eligibility qualification, which I'll talk to. And then there are those individuals. I worked many, many years with folks who had no insurance, who were not, were not citizens of the United States, or many, many factors that limited their access to funding via insurance. So what is available for them if it's not something that that individual can purchase? Looking at different wellness programs that are available in your area that has access to these devices. And in some areas, you may have programs that exist, and in other areas, if you're more rural, that may not exist. I was a part of a team that was very, very blessed in my clinical career that has started multiple programs in the area that I live, not necessarily related to this topic, but we identified gaps in services in our area, and we were able to start programs through writing grants and obtaining grants to bring services and things to individuals with spinal cord injury where we live. So if there isn't a wellness program around you and you think this is something after doing a needs assessment that is important to your clients in your community, and you guys are having a hard time with funding, looking at what other outside of the box ways can we give people access to health and wellness after their injury. So when we are using a supported standing device and we're ready to prescribe either a standing feature on a wheelchair or a standing frame for home, we have to go through that complex rehab technology team. So that includes obviously the client, the PT and or OT, the assistive technology professional, which is going to be the vendor. Lots of clinicians have that assistive technology professional certification. I do in my practice because I deal a lot with complex rehab technology, but I, as the PT, cannot also be the ATP. I do have to have the vendor ATP present from a funding requirement. And then also, obviously, our physician is going to need to recommend and then identifying the funding source because we are going to be speaking to them to obtain funding for these devices. So our letter of medical necessity for these devices is going to be very similar to wheelchairs. So if you work in seating clinic or, whether you use complex rehab technology a lot or just every once in a while, there are resources available to you as to how to write a letter of medical necessity. These are some of the basic things that we as clinicians need to include in our LMN. This QR code is just a resource from the American Physical Therapy Association on the elements to consider for clinical documentation of services for mobility devices, which is a nice starting place. But there are many different tools and available ways that you can get help with your LMN. At Ultimate Medical, just as taking my CU hat off for just a second, there is a program through Ultimate Medical called Justify It that can provide assistance with justification for the pieces of the complex rehab technology that you are prescribing to help with that funding piece that we know sometimes can be difficult to write and timely to write as clinicians in practice. It is very, very important. The difference between a supported standing device and some of the other like wheelchairs or things that we write LMNs for is that we do have to discuss that the client is medically safe to participate in the standing equipment that we have prescribed them, and that equipment does accommodate any medical conditions that they may have. So if we are talking about orthostatic hypotension or limited range of motion, we have to include how is the device that we have chosen accommodating that to be successful for home use. If they are currently using a standing program in clinic, put that in your LMN. It is so important that we say this has been trialed. They have had successful clinical use of this device. They're able to stand upright for 15 minutes with no all of those things are very important to add more robust information and objectivity to your LMN. Also, remember, we've got to have those functional goals. So we've got to create the goals of what this device is going to be utilized for in our LMN. And then also just discuss that any limitations for body functions and structures, again, are being accommodated through this device that you are recommending. This is a QR code from the Clinician Task Force and NCART, which are two incredible organizations that are doing a ton of advocacy work for complex rehab technology. So this is a kind of a what to do resource when you experience a standing device denial. So a lot of times if we get a denial on any complex rehab technology, it's difficult to know what in the world to do as a clinician. So this is a nice guide that is a resource to help through that process. It is important to know that funding for standing devices like standing frames or standing features of wheelchairs, it varies state to state. So there are no two states that have similar, every state has their own rules and regulations. Every payer has their own rules and regulations and qualifications for somebody. So it's not generic that I could say everybody that has this is going to qualify. It really is that specific in the policy of that insurance that individual has. And then also remember that pediatric funding is different than adult funding in many states. So you may work in a population where you see all types of ages. Sometimes it is easier in one area, often I'm going to say pediatric, to get devices than it is for adults, but just know that those are two different funding ways. You can't always say, oh, I couldn't get this for my kiddos. It may be very different for adults. So it's important to consider both. And then again, use the current evidence. So all this evidence that we've discussed today, use pieces of that into your LMN to help strengthen and justify why this technology is important for that individual.
All right, great. So just a couple more here just to wrap things up. So the pathway to personal ownership for exoskeletons is a little bit different than for the standing frames. So I'm not going to read all the steps here. You guys can see they're pretty simple and straightforward. The main piece is that right now an LMN is not actually required. So more so it's our in-house clinical and medical teams work with you and the MD to just collect your medical records and build the medical eligibility case from there. They'll do a trial with a clinical team. They'll train with you all, and then they'll take it home. So next slide, the current payer landscape, sort of the two slam dunks right now for personal exoskeletons are the Veterans Administration. We've had an SOP with them since 2015, as well as straight Medicare. So not Medicare Advantage, not all the other different things just yet. So in terms of slam dunk, absolutely, if you have someone who's eligible and they have one of those two payers, they can get the device essentially. The other ones are workers' comp and private insurance are taken on a case-by-case basis. And so, again, you'll want to start the process as we described. We shouldn't consider this as the first thing. You sort of talk to your patients and then get to the point of having that real conversation of either you have an insurer who has an established policy, this is going to be a somewhat straightforward process, or you don't have an insurer with a straightforward policy, and so we might have to sort of do some work in fighting for it. And then we're done. So the take-home message here, you guys, is that standing and walking goals are obviously important for many individuals following SCI. But the technology needs and goals can change across the lifespan. So it's the right technology at the right time. And then also remember that no single piece of tech is going to meet every goal that an individual may have. So don't be afraid, and they're in different categories as well. So the exoskeletons are now reimbursed in the brace category. So somebody can have an exoskeleton as well as a powered chair, as well as a standing frame. So keep your mind open and start with what your patient really needs and wants, and then take it from there.
Yeah.
And then thinking about proactive intervention, right? So much of our medical system right now is focused on reactive intervention, but we're advocating that we already have a lot of great data that shows the benefits here. So why are we forcing our patients to sort of get to the point where they have these secondary complications and then helping them address them? We're advocating as early as it makes sense, get these folks into this technology so that we can help them actually prevent those secondary complications and live their best lives.
All right, so we'll take questions. Sela's going to go ahead and wrap it up with a little bit of CEU information, and I'm going to start, Jill and I are going to start going through the chat here to check out the different questions. All right.
I see a couple questions about exoskeletons, so I can hop in first. So available for kids, right now they're not, so it's 18 plus. The Indigo doesn't actually have age in their labeling, but there's likely restrictions just related to size requirements. So I would encourage you to reach out to them directly to see about pediatrics, but generally speaking, it's 18 plus. And then there was a question about Medicaid. And so there's not anything established just yet in terms of policies that make it like, quote, a slam dunk for Medicaid. That would be one that we would consider on a case by case.
I do see, Diane, you mentioned something about current literature. I'm not exactly sure. So if you have a specific question, feel free to throw that in there and we will address that. For Jeffrey, I do agree. You said as stated, funding is challenging and there's very heavy scrutiny really there's very heavy scrutiny for all complex rehab technology that we are prescribing, but specifically in standing devices. So as a clinician and as somebody who has been in practice for my entire career, I understand that I am a huge proponent. You don't go into spinal cord injury rehab or neurologic injury rehab without being ready to have your advocacy hat on. If we don't create change, change is never going to happen. It is often led by the end users, the clinicians, the manufacturers, everyone together putting their efforts in to help individuals gain access to these devices. So I am a fan of make them say no. If we don't ask for things that are appropriate and have goals and, all of that, we've done all the steps that we want to do to help this individual gain access to any device. If we don't ask, then the insurance companies win. They're always going to say, well, nobody ever said that this was important to that individual. So identify your different advocacy resources, things like NCART, Clinician Task Force, RESNA. There are many different groups out there. Each of the APTA, AOTA, each one has like their various different groups, but we as a collective, there's a lot of things happening behind the scenes trying to help improve access all across the board of complex rehab technology, but specific to supported standing devices and robotics. And I think those were the big ones that I saw. Awesome. If you do have any kind of questions, please feel free to email myself or Jill, and we are happy to talk one-on-one or answer any questions that you may have. Thanks so much for joining us, guys.